Welcome back to This Week in Immigration. I'm your host, Hanadi Jordan, Communications Associate at the Bipartisan Policy Center. This week, we're taking a look at a pause on nursing visa applications, overall healthcare workforce issues, and the impact on the healthcare industry. We're joined today by Lisa Harootunian, BPC's Associate Director of Health Policy, and this week regular Theresa Cardinal Brown. Stay tuned. Since the pandemic, nurses have been leaving the industry in droves. In the US, about 100,000 registered nurses either left the workforce or retired during the pandemic, according to the National Council of State Boards of Nursing. This has led the US to heavily recruit foreign nurses to fill critical labor gaps. But this week, the State Department indicated that those nurses would have to wait longer to get their green cards, as it moved back the priority date for those that can file their applications this year. Meanwhile, other healthcare occupations, among the fastest growing jobs in the United States, are also seeing extreme challenges in finding enough applicants. These include care workers in nursing homes and healthcare that take care of most elderly and vulnerable. Rural areas have had challenges getting enough primary and other doctors to live and serve those communities. Joining us to delve deeper into these issues is Lisa Harootunian, Associate Director of Health Policy at the Bipartisan Policy Center. Lisa, welcome to the podcast.
Thank you.
We really appreciate you joining us today. I want to start off first by taking a look at the overall workforce challenges facing the healthcare industry right now. We know that during COVID, healthcare workers were on the front lines. Many of us celebrated those heroes, but it was hard on them, and many left the workforce, not unlike other occupations. So, can you tell us about the direct care workforce and the challenge this workforce is currently facing in meeting consumer demands for long-term services and supports and rehabilitative services?
So, first, I want to talk about who the direct care workforce is. There's many ways to slice this, and it can be a very broad group because there's a lot of different names for these workers. But for the purposes of this conversation and the work that BPC is doing in this space, we're defining the direct care workforce to include personal care aides, home health aides, certified nursing aides, and psychiatric aides. And we're looking at those professions across both institutional and home and community-based settings. And these workers, they deliver primarily rehabilitation and long-term services and supports, as you mentioned, to older adults and individuals with disabilities. In particular, they're providing assistance with personal care activities, such as bathing, dressing, using the restroom, meal prep, or other daily living tasks. And when you consider the demographics and composition of this workforce, it really becomes clear that ensuring that we have a strong direct care workforce has major implications for gender and racial equity because 88% of this workforce is comprised of women, 49% of this workforce is women of color, and 22% of this workforce is immigrants. So we really need to do what we can to support this workforce. And now that you all kind of have a better understanding of who the direct care workers are and what they do, I want to talk a little bit about the major shortage of these workers and the implications for the healthcare system and Americans. So the supply of direct care workers is going to fall short of projected demand by nearly 7.9 million jobs from 2020 to 2030. And that raises the question, all right, how did we get here? Well, several factors have really contributed to this worker shortage in the US, making it very difficult for the native-born workforce alone to meet this consumer demand for services that the direct care workers provide. For example, the baby boomer population is retiring, and the demand for LTSS and rehab is significant. By 2030, 1 in 5 US adults age 65 or older are going to need long-term services and supports. And at the same time, thousands of direct care workers left the industry during the pandemic, and many have simply not returned. And this shortage of direct care workers, it really preceded the pandemic, but the pandemic greatly accelerated it. And more than 270,000 nursing home and assisted living facility staff departed between February 2020 to February 2023. And we're seeing this in the home care space as well, because home based direct care workers also left the workforce. And a lot of this was due to fear of contracting COVID-19, fear of infection, and particularly in those congregate care settings like the nursing facilities. And the direct care workforce is one sector that really has not rebounded at the rate that we would have expected. And staffing levels were already insufficient to meet demand well before 2020. But as of March 2023, the nursing and residential care employment is about 8% below those February 2020 levels. So, as you can see, this is a long-standing problem. It was really exacerbated by the pandemic, but there's still a lot of things that we can do to address the shortage now, but the urgency is there. And this shortage is impacting other areas of the healthcare sector. It's really increasing costs to the system, especially hospitals. So, for example, one hospital reports that about a quarter of its patients could move to rehab or long-term care settings if the post-acute care beds were available. And more than half of nursing homes surveyed in 2022 reported that they were limiting new patient admissions due to staffing shortages. So these shortages are really backing up hospital discharges because patients cannot be sent to those post-acute care settings due to the staffing shortages. So we can't really keep kicking this can down the road with this problem. There's really no question that there is a shortage of direct care workers that needs to be addressed yesterday. And to that end, BPC is doing a lot of work in this area to understand the challenges to the growth of the direct care workforce and what those federal policy solutions are to address those challenges. We are working right now on an article that we expect to be released soon through Health Affairs Forefront that's going to be talking about the direct care workforce shortage. And we're also in the process of developing some federal policy recommendations that we're going to release in a report this winter to really help grow the direct care workforce and address those challenges.
You mentioned something really interesting, which is that the workforce shortage existed before COVID. COVID just kind of exacerbated and sped this problem up. So I'm curious, are the challenges that existed before in recruiting and retaining workers the same challenges that we're seeing right now? And if not, what are the key challenges we're seeing today?
Yeah, a lot of those challenges are long-standing challenges. For example, historically low wages is a major issue in this sector, but there's numerous other challenges: inconsistent training requirements, limited training opportunities, inadequate opportunities for career advancement pathways. All of those are just long-standing issues that have really dissuaded individuals from either joining or staying in the direct care workforce. And, solving each of these individually is not going to fix the problem. This is going to require a multifaceted approach that examines all of these challenges and tries to tackle, as many as we can. And just, looking at wages, for example, the median pay for home health and personal care aides was $14.15 per hour, or about $29,430 a year in 2021, compared to $18.08 per hour, or $37,610 a year for a similar occupation, social and human service assistants, with comparable education requirements. So when these folks left the field during the pandemic, and many of them did not return, it's quite possible they went into other similar professions that may be paid more for similar requirements. So that's another major challenge. It's been long standing and was exacerbated also by the COVID pandemic. And with the kind of inconsistent training requirements, I want to talk a little bit about that. Right now, for nurse aides and home health aides who work for Medicare approved agencies, there are some federal training requirements, but those requirements don't exist for personal care aides. And the state requirements also really vary significantly across settings and job titles. So there's just a lot of differences there between professions and opportunities to kind of address that challenge so that these workers have greater mobility across settings, across professions, and we could really maximize the use of that current workforce.
You said that this issue really requires a multifaceted approach. And so I'm curious, what that approach entails and where you see immigration reform playing into that approach. You mentioned immigrants make up roughly 22% of the healthcare workforce. So where could immigration play a role in helping to solve this shortage?
Great question. Well, immigration reform alone isn't going to solve this problem, but it's going to be a really critical component of a larger strategy to not only increase the pipeline of domestic and foreign born workers, but also other efforts to improve supports for workers in these roles. So, looking then at improving opportunities for training, encouraging career lattices, ensuring appropriate benefits and compensation to make sure that these are good and desirable jobs, along with other reforms to maximize the current workforce by better leveraging technology and improving data collection on the workforce. And legislators need to be willing to work across the aisle and focus on bipartisan compromise to really address this major and glaring issue that can't be ignored any longer. Something really has to get done. And I am glad to say that Congress and the administration are paying attention to these workforce shortage issues. In this past February, we saw that the Senate Health Committee had a hearing on healthcare workforce shortages, and the Senate Aging Committee also had a hearing in March on direct care worker shortages specifically. Similarly, in March, we saw that the Senate Health Chairman Bernie Sanders and Ranking Member Bill Cassidy requested stakeholder feedback on the reasons for and opportunities to address the health workforce shortages. And then on the House side, we saw Energy and Commerce Committee Chair Kathy McMorris Rogers released an RFI on improving policies for individuals with disabilities, which is going to require a strong direct care workforce. So if we can build on this momentum around the workforce shortage to see some legislative action that's going to address the shortage through multiple angles, including immigration reform, then maybe we can kind of stem the bleed of workers and reduce turnover in these roles to make sure that we have enough workers available to provide the care that Americans are inevitably going to already need, and that we have the supply of both the domestic and foreign born workers to take care of that and deliver those services.
Congress is taking this issue seriously, as you mentioned. They've held a variety of different hearings to look at this topic. I'm curious, what are some policy reforms you think would help grow the pipeline of direct care workers?
Well, BPC is still in the process of developing a final set of federal policy recommendations to grow the direct care workforce, but I can highlight some really promising opportunities that we are in the process of exploring right now. So, first, there's some bipartisan interest in recapturing unused visas from previous years to increase the number of available employment based visas. And we're considering a similar recommendation that would reserve a portion of those visas for direct care workers, expedite the process to meet this urgent need for direct care workers because domestic workers are not able to fill this demand, and exempting those visas from the per country caps. And then another option we're exploring is recommending that the Department of Labor determine whether there's a shortage of available direct care workers, which we expect that there is, and if so, designate that those professions qualify under Schedule A. And we recognize that Schedule A hasn't been updated in decades, but that's really more reason to do it instead of kind of throwing our hands in the air and saying, oh, it's not going to happen. It's something that should happen and an opportunity that we're exploring. And then next is looking at kind of addressing the backlog of temporary and permanent employment based visas. So, one option there could be Congress increasing resources to USCIS and oversight of how those resources are used to really help address the backlog. And then a couple other areas, we'll be looking at is opportunities to support and improve programs like the Health Profession Opportunity Grants Program that provides job training to qualifying individuals for health professions, including those direct care worker professions, and increasing the number of qualified direct care workers in designated health professional shortage areas. So, really trying to target our reforms to the areas that need it most, like those rural and underserved areas.
Thank you so much, Lisa. We're going to take a quick break. And when we come back, we're going to talk about how the immigration system does or doesn't support the workforce needs of the healthcare sector. Don't go anywhere. And we're back. Theresa, let's turn to you to talk about how immigration fits into this picture. We've talked a little bit about the makeup of the healthcare workforce. So, how many immigrants work in healthcare, and how does the immigration system work for immigrants to come and work in these jobs?
So, immigrants are a really important part of the overall healthcare workforce in the United States. So, as of 2021, the Migration Policy Institute estimated there were 2.8 million immigrants, that is, foreign born people, employed in all of the different healthcare professions. That's more than 18% of the total healthcare workforce. And that's higher than the overall percentage of immigrants in our overall workforce, which is 17%. So, immigrants are overrepresented in healthcare occupations. And that includes 1 in 4 of every doctor or surgeon, physician or surgeon in the United States is a foreign born individual, is an immigrant. 40% of home healthcare aides, one of the occupations that Lisa was talking about, 16% of registered nurses. And so they make up a really important part of the healthcare workforce already. Where they come from, there are also, if you would, an estimates that another 250,000 immigrants in the United States have healthcare educational backgrounds from their countries of origin, but aren't working in those fields in the United States. So that could be for any number of reasons. It may mean that they don't have the right visa category that would allow them to do that. It may mean that they can't meet domestic licensure, or they need re-education to be able to work in some of those fields. So that's another potential pool of existing immigrants in the United States that could be working in some of these fields, but have different barriers to being able to join that workforce. And the workers in the home healthcare industry really come from all over the world, but some notable countries. So about 27% of immigrant registered nurses are from the countries of the Philippines, India, Mexico, and Jamaica, with the Philippines being the largest group of those. Most of the physicians are also from Asian countries in the United States that are foreign born. So Asia is really the area that is supplying a large number of our healthcare immigrant workforce in the United States.
The State Department announced in its May visa bulletin that employment based green cards in the category most used by nurses, the EB3 category, were oversubscribed. What does that mean in layperson's terms, Theresa?
Sure. So let's talk about how we count the visas that we issue each year. So the State Department's visa office is in charge of keeping track of the number of immigrant visas or green cards that the United States issues each year in categories that have caps put on them. So there are 4 family-based immigrant visa categories that have caps. They are mostly relatives of US citizens and green card holders. And then there are 5 employment-based categories that also have annual caps on them. And so the State Department and the U.S. Citizenship and Immigration Service look at how many visas are available each year in each category based on the statute, and how many are available for each country in that year. Then they look at how many cases have been approved for that category from that country, and they estimate how many can get through the system in a fiscal year. When the number of qualified immigrants in a category or from a country exceeds the annual cap, that category and that country are considered oversubscribed, which means not everybody waiting in line is going to be able to get a visa that year. As long as the category, and so what they do is they issue this visa bulletin every month that shows every category and those countries that are oversubscribed, and those categories that are oversubscribed are given a date. So when someone starts the process to get a green card, that initial date is called their priority date, and that sets their place in line. And so basically, when they count out how many people are waiting and how many visas they are available, the original filing date of the first person who's not going to make it becomes what they call the cutoff date. So when they have more people in line than they have available visas, they put a cut-off date. This category that most nurses come under is the employment-based third category of green cards. That's for people who have a bachelor's or at least 2 years of education or experience in their job. And that's most nurses or registered nurses. Up until last month, that category was current for most countries, including the Philippines, which meant that people didn't have to wait much longer than it took to process their cases. There was no country or cap issue. But this year, and this month, State Department looked at it again and said, "Whoop, we have more people in the line than we have visas we can issue this year under the law." And so now they issued a cutoff date, and that cutoff date is July of 2022. So anybody who started their case before July of 2022 can get their green card this year, but anybody who started that process after that is not going to get a green card this year, and they'll have to wait. And since many nurse employers and the recruiters and the nurses themselves have been used to being able to get their green cards on a regular pace, this has created problems because now it means that how long you can expect to wait to get a green card is growing. And it may continue to grow because, as we've already talked about, with certain shortages in the United States, there's more pressure to hire foreign nationals on the immigration under these visas. And so this could become an ongoing and growing problem.
So this cutoff date doesn't necessarily mean that no more green cards will be issued this year, but what happens to new applications?
So if you're starting the process right now, what it means is that you're not entirely sure how long it's going to take before you're going to be able to ultimately get that green card. So we know on average how long it's taking, say, the Department of Labor or US Citizenship and Immigration Services to process these kinds of cases. And that's what we call the processing wait time or the processing backlog. But in addition to that, if there is a limitation, if there's more people in line than the number of visas available, you may get in what's called a cap backlog. And it sounds like, oh, it's not even a year, so you just have another year to wait, except it's not true that once they establish a cutoff date, that date moves 1 month for every month. Because on any given date, and the May cutoff date was July 1st of 2022. On July 1st of 2022, there might have been 150 of these EB3 petitions filed. On July 2nd of 2022, there may have been 850 of these petitions filed. Like, we don't know how many are in each day. And so every month, the State Department does this reevaluation, and it may move forward, or if they're guessing of how many cases will qualify at the end of the day is wrong, it may move back further. So it just creates more uncertainty in the system, that you can't rely on how long it's going to take from the time you start somebody to the time they get their green card and can start working for you.
How are healthcare institutions and organizations responding to this visa freeze, and how has it affected their ability to recruit and retain nurses amid all of this uncertainty?
Well, like any occupation, any employer-based green card category that has had these issues in the past, where there's more people in line than green cards available, it makes it more challenging. If you're relying on being able to sponsor immigrants to support your workforce, the fact that you can't be sure how long it's going to take or how much time it's going to take to get that visa means not only do you not know when you'll be able to have that person able and willing to work for you, it means that recruiting people and trying to tell the immigrant how long they might have to wait is also a challenge. And so I think it ripples down the line. The immigration system is helpful in addressing some of these shortages, not all of them, but some of them only to the extent that the system is kind of reliable and people know what to expect and these visas are available. And when they're not, then the stresses that are already in the healthcare workforce are compounded.
What are some possible solutions or alternatives, if any, to address the nursing shortage caused by this visa freeze?
Well, Lisa mentioned some of the things that have been talked about, such as looking at the number of visas that went unused. So again, the rules for how immigrant visas are allocated each year are really complicated in immigration law. But there's a process by which, if some number of the available family based visas are not used, then they call it spilling down, but they can be used in the following fiscal year by employment based immigrants. So those caps might be exceeded in a given year. But then if those aren't used in the employment based system, then they disappear. And over many, many years, there have been attempts in Congress and arguments made that these visas should not just disappear. Can we get them back somehow? Because it means we're not using all of the visas Congress has allowed us, much less, whether or not we should increase those caps. But if we're not even using all the visas that are available due to any number of things, because the government can't process the cases in time, or during COVID, nobody was allowed to travel, and we lost a lot of visas then. Can we get them back somehow and add them to the caps so that we have more visas available? And there have been bills introduced in the last Congress, last couple of Congresses actually, called the Healthcare Workforce Resilience Act, which would take some of those unused visas, bring them back in, and allow healthcare workers, particularly those who served during COVID, to have access to those. So make more green cards available. So that's one of the things that people are talking about. Some of the other things that Lisa mentioned, like Schedule A, that would shorten the case processing time. It would skip a step at Department of Labor because you're acknowledging there's already a shortage, and then an employer doesn't have to undertake a government supervised recruitment to show they can't find US workers before they hire somebody. But it doesn't necessarily mean, it doesn't make any more green cards available. It would just sort of shorten part of the time. But because our caps are really the biggest limitation, and those are set in statute, it really is going to require Congress to kind of help things out.
What about the other healthcare occupations Lisa spoke about? Does our immigration system provide ways for employers to sponsor foreign workers in those jobs?
So this is a real issue because we have, for example, temporary visas, guest worker visas for short-term and seasonal jobs that don't require a bachelor's degree. Those are the H-2A for agriculture and the H-2B for non-agriculture. But we're not talking about seasonal jobs. We're not even mostly talking about temporary jobs. We're talking about year-round, full-time jobs. And we don't have a temporary visa that would allow an employer to sponsor somebody for a year-round job unless they meet the H-1B standard of requiring a bachelor's degree. And as Lisa said, most of these direct care occupations require less than a bachelor's degree. They require some training and some education, but they're not a degree requirements. And so our temporary immigration system doesn't help at all. So then you have to see, well, can I sponsor somebody for a green card? Well, that EB3 category has two parts to it. One is for jobs that require 2 years or more of training or a bachelor's degree. And some of these jobs might qualify for some of those positions, but they're competing with all of the registered nurses and everybody else who's in that category that has a degree. But there's a sub cap for any job that requires less than 2 years of education, training, or experience. And that is an extremely limited category of about 5,000 visas each year. And it is always oversubscribed. So, I think that the challenge really is that our system is not set up for these kinds of jobs to allow immigrants to come in to supplement the domestic workforce. And that's kind of baked in. I think for a lot of years, it was presumed that the United States didn't have a need for lesser skilled workforce. There were more than enough Americans who are willing or able to do these jobs. But as we're finding, there are fewer and fewer Americans that are taking these jobs, even when they can compete on salary and benefits and other things. But as Lisa said, some of these jobs are really hard jobs. And there's lots of reasons in our medical system why employers, particularly those heavily reliant on, say, Medicare or Medicaid to pay for the work they do, can't just raise the prices for their clients to pay people more, right? There's all kinds of systemic reasons why it's harder to get people to take these jobs inside the United States. And yet, for many, many immigrants, these jobs would be fantastic ways for them to come to the country and start their lives here, and would, be a huge benefit for them and their families. So I think it's a matter of thinking about these things in a somewhat different way than maybe we have traditionally.
We've talked a good bit about where Congress can take action to address this issue, but what about states? What role do they have to play in allowing foreign nationals to work in these jobs?
That statistic I mentioned at the top of this segment, where I talked about almost 250,000 immigrants have some sort of healthcare, education, or training background, but they're not working in occupations here. So most healthcare occupations are licensed at the state level. And, for nurses, for example, they have to take a state based nursing exam. They have to be licensed in the state. And if you're a foreign trained person, you have to take an exam in the United States in English to show that you have adequate education and background and language skills to be able to practice in a healthcare position in the United States. So, some of the things that states are doing to try to help these people who could serve but are barred in some ways is either helping give them support so they can take these exams, so they can get their licensure, maybe allowing them to apprentice or train under existing licensed professionals in their occupation for a period of time so that they can basically learn how we do things in the United States. And that person can then certify, yes, I feel like they are ready to perform these duties in the United States. In some cases, they've also sort of, particularly during COVID, waived some of these requirements entirely for foreign trained physicians and said, as long as you are working with a licensed US physician alongside them, we need all the hands we can get, come on in. And for during the COVID emergency, they kind of loosened some of those things. So I think there are a lot of ways that states can make a difference in at least those immigrants that are already here. And it's worth saying that the United States, even though our regular immigration system really doesn't help us hire people, we have over 300,000 Ukrainians who are here on parole with employment authorization, and they can work anywhere that's willing to hire them. They could be some of these people who have training or would be willing to take training to help in some of these jobs. So I think that there are things that can be done, both maybe in the short term, somewhat in the longer term, particularly at the state and local areas, just matching people that may have skills that may need a little more help to be able to take some of these positions, but seeing what we can do there.
Well, I'm curious, what are the implications of the US hiring healthcare workers from abroad on the healthcare system of other countries? Does this practice of hiring nurses from other countries contribute to nursing shortages in their home countries?
That's a very interesting question. And I think most people look at the Philippines in this particular category because nurses from the Philippines have been coming to the United States for decades now. It's a long established pipeline. But one of the things you find is that means that nurse training schools in the Philippines are really good. and they train many, many, many more nurses than the Philippines can use. So not everybody who trains in nursing in the Philippines is going to come to the United States. But when you establish this kind of, okay, this is something that people from the Philippines can do, it also helps those who are in their countries. So the idea of a brain drain, which has existed in kind of immigration theory for a very long time, it's not kind of as cut and dry as, oh, everybody who has an education or training is coming to the United States. Sometimes there's a feedback loop whereby having people come to the United States in these occupations actually supports more development and more training for people in those home countries and those occupations. And so it's something that we certainly should think about, but it's not necessarily true that we're always depriving countries of their best and the brightest just because they're coming here.
Lisa, let's go back to you. Has BPC put forward any specific recommendations on solving these healthcare workforce shortages, and do any of them so far relate to our immigration system?
Yeah, I'll just, highlight a lot of those recommendations I mentioned previously. All of those are areas that we're continuing to explore as we are preparing to release our report this winter on growing the direct care workforce. And, in addition to all of those, looking at other opportunities that are going to remove barriers to kind of being matched with the consumers who need these services for those immigrant populations who are currently in the US. So, with that, there are successful programs out there that really focus on serving immigrant populations and providing that training on credentials and core competencies to really help develop the workforce, build up those skill sets, and support career lattices and growing in skill development. So, kind of encouraging and supporting those models, I think, could be very beneficial to helping ensure that we are providing the tools and the resources necessary to support a growing and advancing workforce and to match those individuals with the consumers who need those services the most.
Well, we're looking forward to the release of that report. Lisa and Theresa, thank you both for helping us understand these issues better and for joining us today on the podcast.
Thank you.
Thanks so much.
And that's it for our show this week. One last reminder to subscribe, rate, and review this podcast on Apple Podcasts, Stitcher, Spotify, or your favorite podcast platform, and share it with your friends and colleagues. You can also find more information on all of the issues we discuss here on the show at bipartisanpolicy.org/immigration. You can follow the Bipartisan Policy Center on Twitter at BPC_bipartisan. You can follow Theresa Cardinal Brown at BPC_T Brown. For feedback or questions, you can contact us by emailing immigration@bipartisanpolicy.org. I'm Hanadi Jordan. This Week in Immigration was created and executive produced by Theresa Cardinal Brown. This week's episode was written by Hanadi Jordan, Natalie Butler, and Theresa Cardinal Brown. Our audio editor is Joshua Joe. The executive producer of BPC Podcasts is Lucy Manning. See you next time on This Week in Immigration.